Hello, everybody. Thank you so much for having me. I'm Dr. Pavli Demian, interventional physiatrist here at University Orthopaedic Associates, also pain medicine boarded. Marijuana in postoperative pain, I think maybe 10 years ago, would have been just a discussion of can we use it for postoperative pain? Will it help people? Is it something to be considered as an option to give to a patient or patient, or just anything like that? Is it an option? But now I think we approach it not just as an option for post-operative pain management, but given, I know, the legal changes in New Jersey, it is now, I think, become ubiquitous. And so now we have to have the discussion of your patients might be or probably taking it or might be taking it, whether it's for pain, recreational use. How does it affect potential for healing? How does it help pain? And to do that, we're kind of going to break down a little bit of the physiology of marijuana. The different receptors are stimulated on the endocannabinoid system. A role in bone health and healing for some of these cannabinoids. So the most popular two you might have heard are THC and CBD. Potential uses of the whole marijuana plant in postoperative pain management and recovery, and complications of use not just postoperatively, but intraoperatively and preoperatively. So let's kind of start with some definitions. These are really important for being able to kind of talk about what we're going to talk about. First is marijuana. That's just the whole plant. There's different species of marijuana, the two most popular ones, sativa and indica. But that's where you kind of start. So that includes the leaves, dried, the flowers, the stems, and the seeds from the whole plant. And you'll also read a lot about whole plant versus synthetic products, and we'll talk about different ones of those as well. So cannabis just refers to the flowering tops and leaves of the plant. The hemp fiber, the hemp oils, that's where kind of there's been a large kind of push for medicinal purpose, recreational purposes. Right now there's a huge discussion in the United States about, cannabis is illegal federally. It can't be studied. However, THC is illegal federally, can't be studied, but we do have some medicinal uses for synthetic or CBD that kind of confounds things. And if you go, at least in New Jersey, you go around the corner, every corner it seems like there's a dispensary now, and they are, if you look at the numbers, a lot of people are visiting, a lot of people are spending a lot of money there. And so I think it's something that we as healthcare professionals need to talk to about our patients, preoperatively, postoperatively, and also kind of general kind of care of chronic pain. But we'll really just focus on the operative kind of portion of it. The cannabinoids, which I kind of referred to earlier, those are, and we'll really focus on the cannabidiol, which is CBD, and the 9-tetrahydrocannabinol, which is the THC. Those are the two most commonly studied and most commonly studied cannabinoids. Hemp, which is something that's been around for decades and decades and decades, that typically comes from the cannabis sativa plant, and by definition it has to have less than 0.3% THC to be called hemp or to be called sativa, versus cannabis indica, which is the high THC plant and low CBD. So kind of let's really quickly talk about the method of action of the endocannabinoid system. How does it work? I won't geek out on the details too much, but it's involved in pain, appetite, memory, mood, sleep, almost every facet of human kind of physiology. Your body makes its own endocannabinoids. So just like with opioids, your body makes its own opioids. So one of the things that's not well studied is how does supplementation, exogenous supplementation, help or deter or decrease the endogenous production of endocannabinoids. We have our CB1, CB2, and GPR55 receptors, which are the most well-studied and the most prevalent. So the CB1 exists primarily in the central nervous system and on some of the peripheral nerves, but also it's on the bone and in the immune cells of the bone marrow. So again, really important implications for potential healing. So we need to know how each one of those endocannabinoids that interact with those receptors, what do they do, how do they affect healing. CB2, which exists on the CNS and the immune system, but also is involved in neurodefense and in general reduction of inflammation. So where it becomes really interesting is differentiating those, seeing what effect each one of the endocannabinoids, or each effect the cannabinoids that we'll discuss has on those, how it affects each one of those systems, and what are its implications for healing in the orthopedic patient. And last is GPR55, which is on osteoblasts, osteoclasts, the GI tract, and the adrenal glands. So osteoblasts and osteoclasts, clearly the bone metabolizing cells, the large players in that, the GI tract and adrenal glands. And the adrenal glands are huge in the inflammatory cascade. So let's start with CB1. We're going to take our time with them. So bone metabolism action by affecting the sympathetic nerve. So stimulation of the CB1 increases osteoblastic activity initially. And there's a smaller amount of CB1 on the bone cells. So when mice with CB1 knockout, so mice missing that CB1 receptor, it showed initial increase in bone volume, which is potentially great for postoperative healing. However, accelerated age-related osteoporosis. And I think this also kind of brings up one of the more important parts of bone metabolism, is it's not necessarily osteoblastic activity versus osteoclastic activity, but rather it's how do those work together? How do they, which is a little more active, which is a little less active, but increased bone turnover generally means increased bone density and increased potential for healing. CB2 increases osteogenic factor, so increases bone growth. Remember CB2, and we'll talk about this, but CB2 is the one that's more prevalent on the osteoclasts and on the bones themselves. Increased, but also long-term, potential increased osteoporosis. And when looking at knockout mice who had the CB2 receptor knocked out, which means kind of just taken out of their genome, there's disputed results. And a lot of this we're going to see is very disputed results because of the limitation that we have federally on grants to study marijuana. And the GPR55, which is I think one of the really interesting receptors, primarily again within the central nervous system, but also within the osteoblasts and the osteoclasts. So stimulation decreases osteoclast formation, which theoretically results in an increased amount of osteoblastic activity. So it's been shown to have some increased trabecular bone and cartilage remnants at the growth plate. Here's a great cartoon that kind of demonstrates the complexity of how these receptors act on transforming a stem cell, just a pluripotent stem cell, or a mesenchymal or hematopoietic stem cell, into whether it's an osteoblast or an osteoclast. And I think there's a lot to be said for the complexity of this system and how our understanding of bone formation and healing is all about how these different types of cells work in balance, what stimulates one activity versus the other. We have genetic disorders who have increased osteoblastic activities, which theoretically, in the simplified version says, hey, look, we build up so much bone, but we know that bone is fragile. And we know that that increased turnover increases density of bone and increases what you're anchoring to, what your healing looks like. And this is just a nice table to kind of summarize the receptor and how it affects bone formation versus bone resorption. So we'll go through this very quickly. So the CB1 increases stimulation of osteoblastic formation indirectly through peripheral nervous system beta 2 adrenergic receptors, which again kind of goes back to those adrenal glands we mentioned earlier. And less importantly, through direct osteoblastic stimulation. So much more on the osteoblast formation, but less stimulation. So how does that again tie in with the activity of those cells? With regards to bone resorption, it inhibits stimulation of bone resorption through the nervous system. CB2 stimulates the osteoblast formation and bone formation directly because it's located in the osteoblast and stimulates other osteogenic growth factors. But again, we have those conflicting studies with how it affects bone resorption. And the last is that GPR55, which hasn't shown any bone formation correlation, but it does inhibit osteoclast formation and activity directly, which does that kind of tip your balance towards bone building rather than bone resorption. So let's talk about some of our endocannabinoid agonists. So there's the two big ones that we're going to talk about, THC and CBD. So THC is a partial agonist of CB1 and CB2. It has a much higher affinity for CB1. It downregulates the mesenchymal stem cells to differentiate to osteocytes. So you get decreased osteoblast and osteoclast formation. And it also induces caspase-3, which leads to osteocyte death. So not only is it decreasing your formation of osteocytes in general, but it's also decreasing, or it's also causing kind of death of your osteocytes that you need for bone healing. CBD affects the GPR55 and the CB2, and it's an antagonist of those, has less of his affinity for the CB1. It's been shown to have some promising effects for bone healing and bone metabolism, and it's been shown to increase bone bridging across fracture defects, which is helpful in terms of not just fractures, but also kind of surgical healing. Really quickly, again, 10 years ago, I think in my practice and what I was seeing, THC, CBD were hush-hush words. They weren't mentioned in a pain practice. If patients were using them, they were not open about it. Now I find that in my patients, my chronic and acute pain patients, I seldom find someone who's not using a CBD cream or an ointment, or they bought a spray. You know, I've had patients who say, oh, I bought a spray from a gas station, CBD, and I said, I don't know if that's probably the best place to get it, but if you wouldn't get sushi from there, maybe you shouldn't get a spray, a CBD spray. But also I think in our athletes, our college-age athletes, and potentially younger athletes, I think we have to have an honest discussion about the roles of these molecules have on their healing, on their prognosis. And I think like Dr. Buckley mentioned before, it's having that discussion with patients. Look, this is what we know, but this is also what we don't know. And so having that discussion, educating your patient, I think helps to involve the patient in their healing, in their care, and I think shows just long-term better prognosis for the patient. So let's talk about wound healing. Like we said, some of this endocannabinoid receptors are present throughout the skin and the subcutaneous tissues. The anti-inflammatory effects that are particularly with the CBD may help with wound healing. We know we need a little bit of healing, a little bit of inflammation for healing, but an unmitigated kind of runaway inflammatory cascade can deter wound healing and delay wound healing. The CB2 agonism decreases that infiltration by neutrophils and macrophages and also decreases those pro-inflammatory cytokines, which in mice, topical CBD was shown to increase proliferation of keratinocytes and reepithelialization speed, which is helpful for the healing, not just internally, but superficially. The faster you heal, the decreased risk of infection you have. For total joint arthroplasty, this was studied pretty well for total joints, and a lot of these studies too only looked at one form of ingesting marijuana, CBD, THC, and the most common form is smoking, so whether that's vaporized or just smoking the whole plant. So there's decreased radiographic bone healing with smoke, whether that's just as a result of the or the CB1 and CB2 receptors generally, or is that just a result of the smoking and smoking's effect on the microvasculature of the body? How does that, we haven't been able to really tie in a correlation with that. There was a great retrospective cohort study that looked at 2.7 million patients through the Medicare database. And they looked at cannabis users in total knees. And they showed that there was a higher revision rate, cannabis users at 12.8% versus non-users 9.1%. This has subsequently been repeated and largely shown to be the same and repeatable, but not consistent difference. There's other studies that refuted the results as well, but they were kind of looking at N of less than 30 to 50 patients. And also in cannabis users, there's also an increased DVT and PE occurrence. And that's something that delays healing, complicates healing, particularly in our total joint arthroplasty patients who tend to be older and kind of have more fragile health in general. Operative complication, this is something that I think we all see in speaking with our anesthesia colleagues who are present with us. They see that cannabis use, marijuana use complicates intraoperative course. You have the adrenergic stimulation, which we talked about a little bit, giving that tachycardia. Inconsistent effect on platelets. There was a study that linked increased cannabis use with a significant increase in myocardial infarction. That was not repeatable. But largely, intraoperatively, it increases airway edema, just like any other smoking would do, and it damages bronchial endothelial damage, and that complicates your intraoperative course. That complicates your oxygen diffusion across the endothelial lining, and in doing so, complicates your intraoperative course and your postoperative course. So, really quickly, it's a very busy slide. This kind of goes to illustrate the different areas that have been studied, and some trials that have been done, and none of them have been really great, with the exception of one pretty interesting trial that came out of NYU in Jacksonville, and we'll touch on that. But you could see there's pain, nausea, insomnia, weight gain, inflammation, cancer as well. All these things, and I encourage you to go and look up and kind of take a closer look at this, how different products influence each one of these facets of patient care. The other thing that becomes challenging to keep in mind is, well, is it THC or CBD, whole plant versus synthetic plant? So like your dronabinols, which are a synthetic product, versus your whole plant product, which is pretty much what is you can find at your local dispensary or what have you. The ratio of CBD to THC or THC to CBD, there's some very high CBD products with low THC, there's high THC with no CBD, there's high THC with little CBD, there's 50-50 mixes. And their implications and kind of uses are all over the place. And it seems really wild, wild west right now in the medical community with regards to this. But there's one really interesting study that I wanted to touch on, which was published in 2022 out of NYU in Jacksonville, like I mentioned before. And it was a placebo-controlled, double-blinded, randomized trial looking at the implication of buccal CBD. So it's a CBD film that's put in the inside of the cheek, and how it affected postoperative pain. The reason I like this is it was a really interesting study. It was as well designed of a study as I think you can have. And I think it shows a lot of where we are right now in the world of marijuana products and CBD and how we're using that in our post-operative pain, pre-operative pain, and how it's being used in general. So they looked at about 100 patients who were enrolled in the study. They were relatively evenly split. And they looked at them in kind of arthroscopic shoulder surgery. So patients were evaluated on post-op day 1, 2, 7, and 14. They were either given 25 milligrams of CBD, 50 milligrams of CBD, or a sham CBD or a sham film. All the patients were still given Percocet 5-3-25, 1 to 2 tablets every 4 to 6 hours, and they were instructed to self-wean as needed or as soon as possible as they tolerated. The surgical technique, every patient received an interscalene block. There was no catheter, and they were again allowed the Percocet, and they were allowed anything that would be done post-op day 0. So in a post-operative suite, they required anti-nausea medication. If they required additional pain medication, that was allowed. There was no additional blocks given. Patients who required an open biceps tenodesis got it, regardless of their group. The patients were placed in a sling for 2 weeks. They were allowed simple wrist, elbow, hand range of motion exercises, and they were allowed Codman and pendulum exercises as tolerated postoperatively. They looked at, the primary outcome measure was the visual analog scale, which I know everyone hates the visual analog scale, but at a patient bedside, sometimes that's the easiest thing to do. It's the best way, and it's been shown to be helpful in determining how a patient's doing, not comparing them between patients, but if a patient tells you they're out of 10, they come back and they tell you they're out of 5, well, then you know they're feeling somewhat better. Their secondary outcome measures they looked at were post-op patient satisfaction, their overall opioid use as logged by patient, patients on day 1 through 7, then as needed from 8 to 14, and then the potential complications as a result of this. So they looked at LFT, or liver function test elevation, on day 7, day 14. They looked at nausea, and they also looked at the suicidality scale. And they logged their CBD religiously for 14 days. They were instructed to take a TID, so 3 times a day, every 8 hours, regularly, and they logged whether they took it or not. And you can see on that table too the patient characteristics. Pretty well-controlled study, pretty, in the real world, I think it's a pretty well-designed study. Yes, it has its limitations, but definitely kind of helpful to see. So we're going to kind of go through some of these results. So first things first, there was not a lot of, like any good data, you have to read into the data. There might not be some data that's statistically significant. We'll talk about the ones that were and not, but I really appreciate how the study looked at general data and presented the general data, because your eyes can pick up trends, which is very helpful. So day 1 VAS score and patient satisfactory was statistically significant, that CBD was helpful, and again, in addition to their traditional Percocet 5-3-25. If you look at the opioid MME at table 4, can we see that? Perfect. So again, there was decreased opioids, but a lot of variability within the standard deviation. It was not statistically significant. Looking at, now kind of we'll turn our attention to table 3 here. Looking at the VAS scores, yes, there's not statistical significance on day 2, day 7, or day 14, but there is a trend for a decreased pain score, which again shows you that there's a potential there. And we'll talk about the differences between the two groups of the 25 milligrams and 50 milligrams at a later slide. Patient satisfaction also kind of showed very similar trends of if not better, then the same. So nothing worse, which is helpful, which also kind of goes to show how much of this was pain versus patient satisfaction scores are always really helpful for me as the kind of pain doctor who sees chronic and acute pain, because it's kind of the functional quick one question, how are you doing? How are you feeling? It's that ability to, and you can't show it on a study, you walk into a patient room post-operatively and they're either smiling, and then you know, all right, this is where the setting is going to be, this is where we're going to go, versus if they, their face, they're upset, they're in agony, they can't sit still, and you know how they're doing just by the look on their face. So I always really appreciate satisfaction scores in studies. You could also look at the implication on nausea, which is one of the big side effects of opioids. And again, it's shown to have a dose-dependent correlation with opioids. But also, THC can induce kind of a hyperemesis syndrome. CBD, less so seen, that correlation, but it also does, it is also seen sometimes. But again, we're kind of at the wild, wild west. We don't know exactly, we don't have a standardized product for the CBD and THC, outside of the study rather. This is looking at this is an interesting breakdown, table 5 here, of looking at the patients who got 25 milligrams of CBD, 50 milligrams of CBD versus the 0 milligrams of CBD with the sham films, and just the opioids. So looking at their VAS score, looking at the patient satisfaction score. And I think this is really, really valuable. And here, your day 1 and your day 2 patient satisfaction scores. It's funny because a lot of the VAS score kind of data really falls apart at day 2. And again, it's not necessarily worse. The trending better, but not statistically significant. And then at day 7 and day 14, you can kind of look at those for yourself. Not a lot of statistical significance, but certainly there's trends there that are helpful. And it also looks like there's a trend that an increased amount of CBD is more helpful than the decreased amount of CBD. So an improved 50 milligram VAS score at day 7, and as opposed to the 25 milligram, and same at day 14 there. And then the nausea levels and opioid MMEs, kind of looking at these going throughout the day 1, day 2, day 7, and day 14. And again, you can see not a lot of statistical significance, but your eyes lend to a trend there. So, there tends to be decreased opioid use, which is always helpful, especially in our patients who are more at risk. So those are younger, who have an increased score potentially on an opioid risk tool. And also in nausea as well, although that seems to kind of dissipate after day 2 across most of the groups. This is a kind of really great table. I'll let you kind of go over it on your own, but really comparing the CBD 50 to 25 and then the control to 25 and the control to 50. You could see here that there was a statistical significance for patient satisfaction on the different dosage of the CBDs, and also on nausea on day 2, and the CBD is on day 1. So really what that study shows is that there's a place, I think, for further investigation. I think a lot of the data also presented shows that there is likely an inhibition on healing from THC, but CBD has some potential, like any kind of disclaimer. Unfortunately, it warrants further studies, but I really like that study because it shows what we potentially can do to investigate further and how it relates to, your acute pain management in that time. And the other thing to also consider is it's not just a separation. Opioids are bad. No opioids ever for anybody. Opioids have certainly, and everybody has their own opinion about that, but we need to treat people's pain effectively. But if we can get away with significantly less opioids using CBD, then maybe that's a helpful option. In the future, this was an N of about 100, so we're kind of limited in what we can extrapolate for that. Any questions? Thank you so much.
Couple quick questions for you. Speed round.
Yes.
Right?
Yes.
So an athlete comes to you and says, well, I just had ACL surgery. I've got some pain. Will CBD or marijuana help me in my recovery?
So the answer I would say then is I would stay away from THC products because some of the data shows that it impairs healing. Whether there's a CBD product that can help, there's enough evidence, I think, now to say that it does not impair healing in the same way THC does. But I would maybe have an honest discussion of, look, we know it's the first just operative period. If you could stay away from that, that would be great. The other thing to kind of address that CBD and THC are used for is anxiety. And an athlete's post-operative angst is a real thing. Will I get back to playing? They may have a scholarship riding on it, or they have kind of a future potentially professionally. Dealing with that angst, addressing that angst is a huge part of this. It's a huge part of pain perception, and it's a kind of an area where sports psychology really comes into play and can be helpful for patients. So again, it's having that discussion with them. Here's what we know. Here's what we don't know. Here's the limitation of the studies that we have.
CBD or THC, good or bad for a recovering stress fracture patient?
So preliminary, again, based on that preliminary data, THC I would stay away from. CBD, you can consider it. But we do also have some pretty good data for traditional treatment. But perhaps CBD supplementation might be helpful.
People that have got insomnia or difficulty sleeping, impact of CBD or THC on improving sleep?
So this is this is my personal take. I'd rather patients try a CBD with a low THC option than be taking benzos chronically forever. We know the long-term studies of benzodiazepines and other sleep aids are not great. There's some great data out of the traumatic brain injury medicine that shows chronic use in traumatic brain injury of benzodiazepines leads to decreased cognition. So I'm more inclined to advise my patients stay away from that. I would maybe say high CBD, low THC for sleep might be helpful.
Use of CBD or THC as a pre-rehab medication.
No.
To minimize pain through the rehab process.
Before surgery or pre-rehab?
No, they're post-surgical.
Post-surgical.
They're going through the rehab process, but in the rehab process, whether they got to regain range of motion or kind of pain with rehab, do you offer taking CBD or THC prior to your rehab session?
I would again push people away from THC.
Okay. Then another question, maybe off the wall a little bit, but we sometimes will use ultrasound in the form of phonophoresis to drive in anti-inflammatories.
Yes. Fascinating place to study.
Do you do phonophoresis with CBD oil or THC oil?
I would not do it with THC oil. I would avoid THC oil. CBD oil, I did not see much data about that. Maybe that's a really great option, great kind of way to look forward. I think phonophoresis, electrophoresis are really interesting places. And we know that if there's a patient having this kind of runaway inflammatory cascade that's maybe not responding to traditional healing, perhaps some immune modulation using CBD can be helpful. I'd like to see some more studies about that, and I think that would be fun to kind of look going forward.
Pain perception from somebody who's a daily user of THC versus somebody who just recreationally uses it?
Doesn't matter. Both groups of patients will require higher postoperative opioid doses for adequate pain relief. And that's been pretty substantiated. They will require increased amount of sedative and anesthetic medications intraoperatively.
So are we at the point, since marijuana is legalized and we can talk about it in public now, is this something we should be including on our medical history or intake forms?
I think it's mandatory. It's going to give you would want to know if you're having some sort of surgery, any kind of orthopedic surgery, you would want to know whether you're anchoring, or you're replacing a joint or whatever it may be, you would want to know what the patient's bone density is like. And so given the role that THC and CBD has, that we know it has in bone density, we'd want to know that.
Last question, one from online, is would you ever recommend using any product for the high school age athlete?
No. The implications on THC in a developing brain has been widely shown on repeated studies to decrease functional cognition and impair social emotional quotients for a developing brain. The developing brain, you've got to hold on to that thing tight, and you got to take real good care of it. And maybe this is just because I have 3 kids and they're all boys and pretty stupid boys. Maybe that's just my bias as well. Yeah, Dr. Swan.
Great talk, Pavli. Thank you.
you.
Can you just clarify what has happened with the legalization of marijuana in the various states, but not federally, up until it was legalized in the states? We had no research at all? Like, it wasn't legal to research it, and now we have some studies at the state level, but we don't have federal grants? Like, what's the story there?
So because it's a restricted drug federally, no federal grant money can be put to studying marijuana or THC. Mind you, opioids can be studied and are studied, obviously. Cocaine can be studied, but not marijuana. What has happened? A lot of the studies that were initially reviewed before the push for legalization within the states, a lot of the studies were coming out of Europe, who have they've been using marijuana for decades and decades and decades, and a lot of it actually Amsterdam, where there's a lot of there's a ubiquitousness of marijuana in Amsterdam, and there's a lack of taboo associated with it, so it's been studied there. Now what we're seeing a lot of is state funds being used for this. Non-funded studies just being done, and those can be done within all the states, but there's still some states that won't let you study it because it's illegal in that state, and they just want to kind of close their eyes and ignore it. And before the push for legalization in states, a lot of the studies that were happening were just based on what people were getting off the streets. There wasn't a stress on how much dosage are they getting, how much milligrams of THC, how much milligrams of CBD. They're essentially just comparing whatever you were getting off the streets to whatever you're getting off the streets. A lot of retrospective cohort studies going like, hey, do you use cannabis? Okay, great. You're under the cannabis usage, not how much, what dose do you get. And now I think with the push for legalization, there's become a real push to look at the dosages, look at the quality of the product, whole versus synthetic products. Because in addition to the THC and the CBD, there's about 400 other cannabinoids that are in the plant, things like terpenes and things like that are also have an effect. And kind of some preliminary studies looking at whole products versus synthetic products show that there's a difference between those, even if the THC content is controlled. So it tells you there's other endocannabinoids that are doing something, and unfortunately we just don't have the robust data to show what it is. And I also think it's going to be a lot slower because we don't have that pharmaceutical push, because now it's already legal. So anybody can come up with their own mix, and it's under a lot less stringent kind of reviews compared to like a traditional pharmaceutical medication.
Thanks, Pavli. It's actually a good segue for my question. I vaguely remember seeing development of like a seizure drug with this kind of as the mechanism of action, and is that still going on? And then are we seeing patients who have that, and has there been any talk about then the pain in response to that, or is that fallen by the wayside as becoming more ubiquitous day to day?
So I think that's a great question, and I think it shows the socio-political space that marijuana has existed. So I think maybe 10, 15 years ago there was a lot of stories of like, oh, I have a kid who were using kind of the oils from the plant and it helps their seizures, but it's illegal, so the parents were going and obtaining the plant illicitly from growers, and it was a really big kind of story. And it kind of has fallen somewhat by the wayside. I really focused on the orthopedic implications of marijuana for this. But I have a feeling a lot of that story was maybe there to kind of push, not saying it wasn't helpful, but there's things that come into the news cycle for reasons. And if there was a huge push, this is a multi-billion-dollar, it's the fastest growing industry, or one of the fastest growing industries in America, is marijuana. And so I think that, you have to kind of be wise to that push. Why was that push there? I'm not saying it wasn't helpful, but I think I did not come across any astounding results. I'm not saying it's not potentially there, but I think until the federal ban is lifted, you can't get great evidence. And the pharmaceutical companies are just not going to invest that money to look at that potential. Great. All right. Thank you, everybody.
Thank you.